Welcome back to the Healthy Chicago podcast, where local health professionals and their guests discuss the latest public health issues affecting Chicagoans.
Hello, Chicago. Welcome back to another episode of Healthy Chicago podcast. You know me. I am the city's doctor. I am Dr. Olusimbo Ige, and it is my job to help keep Chicago safe. A little about me, a reminder for those who are new to the show. My background is in public health. I'm a public health physician by training, and what that means is I like to keep people from the hospital. So prevention is my thing, and that involves making sure we identify threats and mitigate those threats as quickly as we can so that people can live safe, healthy lives in the city of Chicago. So today I have here with me my friend, my colleague, my business associate, whatever you call it, and he's a deputy commissioner for behavioral health. And so I want you to introduce yourself, Matt, and tell people a little about your background, how long you've been in this role, and some of your passions, and a little bit about you.
Sure. No, thank you. Thanks for inviting me to do this with you, Dr. Ige. So I'm Matt Richards. I'm the Deputy Commissioner for Behavioral Health. I'm a licensed clinical social worker by training. I also have an MDiv, which I can say with that. That's basically I was trained to do pastoral care and chaplaincy. And so I oversee the department's mental health, substance use, violence prevention, and then some of our work with folks experiencing homelessness. And my primary clinical passion is probably substance use disorders, which we're going to be talking about today. I've done a lot of work as a clinician providing direct services and treatment for people with substance use disorders and co-occurring mental health conditions. And then, like you, I'm trained in public health. So I think about population mental health. How do you promote people's mental health and well-being before there's a problem, rather than just delivering treatment services.
Right. Well, Matt, I know you. We've spent hours together. I know that you are full of compassion. You're full of zeal for this work. And I just wanted people to see a little bit about, who you are and what you bring to this role. So, we talked about population health. We talk about the health of Chicagoans. And there are certain trends that have become concerning with regards to the opioid use crisis. We're seeing it all over the country, but there's something that is happening in Chicago that is making us worried. Can you share some of the changing trends that you have seen? Given your background and your years of experience in this space, what are some of the new things that you are seeing that's a concern?
Yeah, so if you think about, for instance, opioid use disorder and drug overdose deaths in the city, there's multiple waves of that. So the first wave of it was really related to, quote unquote, illicit heroin use, crack cocaine, things like that. Going back to, let's say, the mid-20th century. Crack cocaine becomes a problem later than that. But heroin use disorder is not a new phenomenon, right? Then you have the prescription, over-prescribing, inappropriate prescribing of opioids, right? Which we associate with, like, the 90s, through, let's say, 2010, 2015. And then you have folks who became addicted to opioid pain medication who then, once it was more difficult to secure those medications because they started to be regulated more carefully, start using illicit drugs again, heroin, etc. And then what we started to see, when we've seen this over the last decade, is a transition from illicit drugs that were really plant-based to laboratory-based. And that has represented a real challenge because the laboratory-based drugs are becoming increasingly more potent. There's lots of different analogs in the drug supply now, so you don't ever really know what you're using. And we have just seen an exponential increase in the number of people dying from drug overdose deaths. And that largely corresponds to the amount of fentanyl in the drug supply. So in 2015, if you looked at our data of people who died of a drug overdose, like 10% of people had fentanyl in their toxicology test. Now it's 95%.
Whoa.
And as you know, we just had a recent spate of drug overdoses a couple weeks ago, and we were one of the first cities to kind of take the lead on this. There was an animal tranquilizer that was implicated in those cases, along with other components like fentanyl. So that's been we now have more people dying per year in Chicago, approximately 1,300 of drug overdoses, which is more than homicide and vehicular death combined.
Wow. Can you say that again? That is staggering.
It is staggering. 1,300 people a year dying of drug overdoses in the city of Chicago, which is more than homicide and vehicular injury, so car-related automobile accident injury combined. There was just a story in the New York Times 2 weeks ago about 1,000 people a year dying of drug overdose in Baltimore. Wow. Baltimore is not a very large city. You've had 6,000 people die in 6 years. And we have to really reflect on, why has this not been treated like an emergency in some places?
Yeah.
We have sought to treat it like the emergency that it is, and I know you and I will talk more about that. But I think we have to reflect on who have these conditions disproportionately impacted, and how has that influenced our sense of urgency about it.
Right. And thank you so much for just putting that into context and helping us see the magnitude of the issue. In CDPH, we talk about anti-racist approaches and putting in the center those who have been in the margins. And that includes just encouraging societal attention on issues that disproportionately impact certain populations. So I have heard you talk about, why is this not getting the attention that it deserves? Why is this not becoming an emergency? Why are we not having the societal attention and resources deployed in this area? But before we go into that and who are those impacted and why, can you tell us a little about what is substance use disorder?
Yeah, that's a great question, because we talk about it a lot, but we're not always clear about what we mean. So what we mean is a pattern of using a substance that causes significant impairment and creates negative consequences, but persists in light of those consequences.
Right.
So when we say negative consequences, it affects your ability to work. It has negative health consequences. It causes interpersonal problems.
Right.
It affects your ability to do things that are important to you. So we actually really look at patterns of use that are connected to impairment. And what are some of the features of that? It's a kind of narrowing of focus. People tend to start spending lots of time thinking about the substances they're using and spending a lot of time trying to acquire those substances. There's an experience of loss of control, like despite maybe one's desire to limit one's use or control one's use or cease one's use, finding it difficult to do so. In the more sort of serious stages or more advanced stages of it, the use becomes quite chaotic and compulsive. People may experience withdrawal symptoms. There may be other physiologic symptoms that you experience as well. So that's what we mean. There's not a lab test that tells you, does Matt have a substance use disorder? It's really a comprehensive evaluation based on how the use affects the person's whole life.
Right. So there are a few things that you've described now that is very fascinating. You're saying in spite of negative consequences. I think that is really important to emphasize, because there are folks who feel like the negative consequences should stop people from using. But you're saying that substance use disorder means that in spite of the negative consequences the individual is experiencing and its impact on their daily living and work and functioning, these individuals feel a compulsion and are still not able to control their impulses because it is a substance use disorder.
That's right.
Right. So that is very important, because in looking at how we tackle this, I think that understanding of what this disorder is and the lack of control that accompanies it is a critical part of making this diagnosis. I could not agree more.
I mean, I always tell people, I'm trained as a therapist. The analogy I use is it's a little bit like obsessive compulsive disorder. We've started to think about addictions more on the continuum of OCD. Right. Because what happens with OCD is people experience intrusive thoughts and internal compulsions to engage in a behavior, and then they engage in sort of compulsive behaviors in relationship to those thoughts. And people can develop really complex ritualistic, constellations of behaviors related to that. And one of the things is, despite my best efforts, I feel like I have to walk down my stairs of my building and up again and jiggle the keys in the lock 5 times before... And if I don't, something bad's going to happen, right? There's a whole set of interventions we use to address that. Substance use disorder can be very similar to that. People develop these very compulsive patterns of use. And it also applies to addictions which are not related to substances, which we will call behavioral addictions or process addictions. So that's one thing that's at play in that. Another thing that's in play is withdrawal. People start to experience cravings and withdrawal symptoms depending on the substance you use. And that affects a person's continued use as well. They're either trying to stave off the cravings, stave off the withdrawal symptoms. People use substances very frequently to manage difficult internal experiences related to trauma, anxiety, depression, etc.
Thank you. That's very helpful. In our work in public health, we always describe an issue in terms of what it is we're dealing with, and then who it is that's impacted, and then, where and how.
Yes.
So before we go to the who, because I know that there is a lot of emphasis in who is impacted, are there biological factors that predispose to substance use? Are there environmental conditions or social conditions that predispose to substance use? Before we go to the who, so that we can sort of start weaving the thread to better understand the who is most impacted, because these are some factors that we've seen as contributing or predisposing to this disorder.
Yeah, that's a great question. So I think we think about it's sort of a range of factors. So we do think about genetics in terms of genetic risk, like do you have a family history of addiction or of substance use disorder? We think about social factors. So we know, for instance, that people who are experiencing, I'm going to use it, long-term unemployment, they're at higher risk of developing a substance use disorder. We think about developmental experiences. So that's if you experience complex trauma as a child, you have significantly elevated risk. If you have a high ACE score, adverse childhood experience score, you have significantly elevated risk for developing a substance use disorder. So I always think about sort of genetic, biological, social, and developmental. That's sort of the categories I use to describe risk.
That is very, very helpful. So we see how some of these factors set the stage for, this disorder. And then we start layering that with, this proliferation of synthetic or laboratory-based substances and how widespread that is.
Yes.
So there are folks, because of the generational trauma or environmental factors or social disadvantage, that are more susceptible to this marketing of now more widely available laboratory-based substances.
Yes.
And then once you start that, you feel like you're self-medicating, you're looking for temporary relief, and then this cascade of compulsion and physiological withdrawal and things now layer onto that.
I think that's a great way to describe it. And your phrase cascade, I think that's a very good way to describe it.
Yeah. This is very helpful because if we don't understand what we're dealing with, then the remedies or the interventions and the opportunities to address this as a public health issue is limited. And it's one of the reasons why in CDPH we're exploring all of the public health options rather than just the criminalization or punitive measures, because again, in spite of negative consequences, a substance use disorder compels the individual to keep going back, to keep using because there is something that's gone awry. And these individuals need more help to stay in recovery. So we are in a crisis in Chicago.
Yes.
We made an announcement because we were concerned. We wanted to treat this as an emergency. We wanted to prioritize communities that are most impacted. We wanted to call for societal attention on this issue, and we wanted to call for action and everyone to participate. So what are the options? Someone has substance use disorder. And now we're seeing more overdoses than before because of this proliferation of laboratory-based synthetic. And we're seeing more people die from overdoses than from violence or road traffic accident. What are the options?
Yes. So that's a great question. And I'm going to say a few things about that. So one is when you look at a map of Chicago, there's some interesting things that you notice when you look at alcohol use disorder versus, for instance, opioid use disorder. Different parts of the city and different demographic groups are at risk. So alcohol use disorder, we see the highest rates of that on the southwest side, on the northwest side, in the Loop, like up the lake shore on the north side. On the disproportionately impacting whites and Latinos and disproportionately males.
I see.
What you see with opioid use disorder is it disproportionately impacting the west side of the city and the mid-south area of the city. So Auburn, Gresham, Chatham, Inglewood, West Inglewood, that part of the south side, and disproportionately impacting African Americans and specifically males. So, when you look nationally, there's interesting differences in terms of our demographic patterns versus the national patterns. For instance, you see opioid use disorder impacting disinvested parts of the upper Midwest where there was deindustrialization and things like that. So as a public health person, I think about, like you, primary prevention, secondary prevention, tertiary prevention. And I'll use less jargony language to describe what I mean. So we don't talk enough about preventing substance use disorders. We usually go right to treatment. And I think in an emergency, we have to do immediate things, but we also have to think, how do we prevent the sheer numbers of people that are developing these disorders? So I think one thing we know is that, parts of the country and demographic groups that are at elevated risk are typically in parts of the country where you see a lot of systemic disinvestment, high levels of job loss, economic instability, income instability, precarious social conditions in people's lives. And so that's where when you and I are speaking to our colleagues, for instance, in urban planning and development, when we're talking with our colleagues in the infrastructure department, we have to be, our partners at CPS, we have to be thinking about the neighborhood conditions. Investment, creating opportunity for people so they feel better about the prospects of their life, that life is worth living for, that there are things that give them a sense of meaning and purpose, that they feel safe. All of those things are part of prevention of substance use disorders. I think in terms of the crisis that we're in right now, we are doing a number of different things. So one thing that we're doing is we're trying to get the areas most impacted saturated with harm reduction supplies. So naloxone, which is a drug reversal agent that you can be injected up someone's nose. We're making that widely available in the most impacted communities. Drug checking supplies, so people can check substances before they use them to see if they have a component in them that would create an elevated risk of a drug overdose. Providing public health education about, if you are using substances, not using alone, so that if you do experience an overdose, there's somebody there to perform to administer the naloxone and contact first responders. So a lot of the work we're doing right now in this emergency phase is coordinating all of our stakeholders around the city to increase access to harm reduction supplies and get people who are at elevated risk started on buprenorphine and methadone. So those are medications that are FDA approved that we know significantly reduce risk of drug overdose. So if you take those medications, you're 40 to 60% less likely to experience a drug overdose. They are not just medications used for treatment. They are medications used to prevent overdose, even if you are using substances. And that's a critical point. So that's one part of what we're doing, this coordination of getting people access to these interventions that reduce your risk of overdose. The second thing is simplifying access to treatment. If you compare the United States to other countries like Portugal, in Portugal, they've made it very easy to get access to treatment. Treatment is free. No one is turned away. There's one number to call. We'll come and pick you up. We'll get you into treatment. A lot of the time in the United States, if you have Medicaid, if you don't have insurance, if you have limited income, it's easier to get access to the medications to which you're addicted than to get treatment. That's a problem. So one of the things we've been trying to do is work with the Illinois Division of Human Services around really leveraging their opioid helpline. We've made a program available, MAR now, Medication Assisted Recovery Now. Anybody in Chicago can call that number. You will get screened over the phone by a prescriber who will determine what sort of treatment interventions you need, including medication, and can start you the same day.
Right.
You can go to the pharmacy, pick it up. We'll bring the meds to you. We'll help you get into a level of treatment that's appropriate for you. It could be outpatient. It could be intensive outpatient. It could be residential. So it's making it easier for people to get into treatment. And I think a third thing is really continuing to work on, ending the criminalization of behavioral health.
Right.
Behavioral health conditions and substance use disorder in particular have been treated as really personal failings. More people end up in jail because of personal use amount of drugs than for any other reason. That's been a primary driver of the explosion of incarcerated people in the United States, and it just makes people's trajectory worse.
Right.
So we have projects like the Narcotics Arrest Diversion Program in Chicago, which is one of the largest law enforcement-led diversion programs in the country, where over 2,000 people have been diverted into treatment through that program rather than going into the jail system. So we have to continue to kind of intercept people, if you will, before they go into those systems and get them connected to treatment, get them connected to harm reduction, while still working on these bigger picture issues related to prevention and how it's connected to investment in communities and people.
Yeah, thank you so much. I know that you're very passionate, and we thank you for your leadership in this space and the work that we're doing to get resources to those that need it and the communities that are most impacted. So I want you to describe again, if, let's say, I am a mother and I have, a child that has substance use disorder.
Yeah.
How do I access this MAR now? What are the steps that I need to take to get my loved one connected to treatment in the city of Chicago? Can you walk us through that process?
Yeah. So if we're talking about a child, and you're noticing patterns of substance use that are concerning, what I always recommend as a starting point is to work with your pediatrician. So pediatricians at this point, if you're a pediatrician, let me put it to you this way. If your pediatrician is not equipped to help assess your child's substance use, you might want to consider getting a different pediatrician, because that is just the expectation now, is that whether it's with an adult or a child, that these are health conditions and primary care providers need to know how to assess for them and determine what level of care is appropriate. And what a pediatrician in that circumstance will do is they'll speak with your child, they'll speak with you to understand what's the nature of what we're dealing with. Are we talking what types of substances? Right. How is it impacting this young person? And then they will likely work with you to make a referral to a treatment provider, which will be done based on, whether you have insurance. All children in Illinois should have insurance, whether through Medicaid or through a commercial payer, and get your child connected to a substance use provider who specializes in working with young people. We have lots of great providers around the city who specialize in working with children. You can also go to our website, overcomeopioids.org, or you can call the Illinois Opioid Helpline and let them know what your need is. They have access to a resource directory, and you'll actually speak to a navigator who will help you assess what is it that your child needs and help make that connection.
Yeah. Thank you very much, Matt. And I flag that because recently we have heard of an unfortunate incident where a student at one of our public schools overdosed. So what we're saying is, whether it is a child or an adult, there are resources available. There is help available. There are pathways for families to get their loved ones connected to the support that they need. So I want to talk a little about stigma.
Yeah.
Yesterday, I was reading the feedback from one of our partners who's out there on the streets taking the Narcan supplies to the community so it's easy. And, they're saying, well, will you like a Narcan? And there are folks who will look, they probably want it, but they're also worried about what people might think about them, getting supplies of Narcan and how people might look at them if they think they have substance use disorder. And this is part of the reason why we're having this conversation, so that people better understand what substance use disorder is and how can we address the stigma, and help people understand that we want folks to seek help because help is available, and we want folks to be able to leave so that they can get connected to recovery.
Yes.
There are options available, there are resources available, but we want folks to feel comfortable doing that. What are some of the work and the encouragement and the call to action in that area, and just addressing the stigma around substance use, even accessing treatment?
Yeah, there's so much, in that. So I think one thing is telling your story. I grew up in a family where multiple of my family members and my family of origin had substance use disorders. And so I'm very open about that. And all my family members are in recovery. And I'm very proud of that because I've seen their journey and how difficult it was. And sometimes I think in my role, people assume, you're some sort of disconnected city bureaucrat. You don't really know. I know more than I wish I knew. And it is because of my personal experience. And so I talk very openly about that. And I help a lot of people outside of my job too get connected to what they need. And, I've seen it with my own family members is sometimes with addictions, people are treated with a real lack of understanding and kindness. There's an incredible amount of judgmentalism because people just don't understand. This is fundamentally a health condition which is rooted in an attempt to manage your suffering.
Right.
That is what it is. Any person I work with an addiction, they are experiencing suffering.
Right.
And so I try to first start with kindness and compassion before we do any of the clinical stuff about like what they might need and what they might benefit from. And so tell your story. I have people in my life who've lost children to drug overdose who did not feel like they could tell any of their family members that their child died of an overdose for fear of judgment and said, oh, my child died of an asthma attack.
Right.
My child died of diabetes. Can you imagine going through your life, losing your child and not even being able to talk about this? That's so heartbreaking to me to imagine that. We have a campaign called Unspoken, which is our behavioral health campaign that's about addressing stigma and helping people get connected to the help they need. And it's about people telling their stories. And it features people telling their own stories of recovery, which I think is really powerful. 20 million Americans are in recovery. That's an astounding number. 20 million Americans are in recovery, right? So recovery is not only possible, it's everywhere. It does. If you know people, if you leave your house, you know people in recovery, right? I have a ton of people in my life who are in recovery. And that journey of finding recovery really is a powerful human experience that changes your sense of what matters about life. Some of the most amazing people I know are in recovery, and it's because of their journey. And so I think that's another part of it. I think in the healthcare system and public health system, we have to hold ourselves accountable. You have incredible power when you work with a person. And if you might be this may be the only opportunity for them. Right. If you shame them, if you layer on their trauma, you could be impacting them in going down a road that's going to lead to morbidity and mortality for them. You could also be the person that helps them see a new path of possibility. And so you have to really take that responsibility seriously.
Thank you, Matt. That is so powerful. I had the privilege of working with amazing colleagues when I was in New York City who were themselves in recovery as peer specialists, as, even people in positions of leadership. So sharing their stories is just such a powerful way of destigmatizing this and helping to create hope and helping people know that recovery is possible. And there are many people around us who are going through these experiences. So we want you to know you're not alone. We want you to check our website on Unspoken so that you can also read other people's story and know that you are not alone here. So we want to talk about one last bit of this. I always talk about putting the public in public health.
Yes.
You've talked about professionals. You've talked about public health folks who are helping to lead this. What can the average person, Chicagoan, do to help? What are 1, 2, 3 steps that they can take to support us in this work and so that they can be part of the solution?
That's a great question. So I think there's a few different things that I would say. So I think one is educating yourself about substance use disorders. So when people in your life need help, you can skillfully provide it. You don't need to be an expert. You don't have to be an addiction medicine doctor. Right. You have to be somebody who can be a non-judgmental, compassionate presence that can help people feel okay asking for help. So it's really about being that non-judgmental presence and then knowing, okay, what can I refer this person to? And that's where it's referring people to the Illinois Opioid Helpline, and we'll provide that information when we post this podcast. Going to our Overcome Opioids website. Accessing the materials in our Unspoken campaign. So that's one thing. I think the second thing is advocacy. We still do not have parity related to the typically health insurance companies do not have to pay the same amount for behavioral health services that they do for physical health services. And we have to continue to advocate for increased funding for behavioral health, substance use, and mental health services in this country to continue to build those systems, to make them as easy to access as easy to access and high quality as we do with our safety net primary care system. And I think investment and advocacy around investment also involves advocacy for investment in your neighborhood. Go back to our point about prevention. When you invest in public schools, when you invest in infrastructure, when you invest in housing, when you invest in green space and neighborhood conditions, right? All of that, when generous social safety net for people who've lost their jobs, that is part of the prevention cascade for substance use disorders. And that may seem like a long game. In a certain sense it is, but we start to see the benefits as those investments are made. Right. I think the last part is telling your story. Right. The recovery experience is an incredibly life-changing experience, and it gives you insight into the human condition that gives you a lot of wisdom about what makes life matter. And so really encouraging people to be proud to tell your story. Right. Shame is kind of a very powerful force that can take hold of our lives. If we don't counteract it with owning our story. And I think owning our story and being proud to share it is critical.
Thank you so much, Matt. And I'm going to start from there, folks. This is how you can help. Would you tell your story? Would you share your experience so that others who are working on the same road as you can be encouraged and become more hopeful about their own path and their own journey to recovery? And folks, would you educate yourself? Would you take a moment to check out what substance use disorder really is? How can you support the members of your family, friends, loved one, colleagues who are struggling with a substance use disorder? How can you be that compassionate, supportive influence to those who are living with a disorder around you? Number 3, how can you use your voice to be a change agent in your community? Where are there opportunities to elevate the needs in your community to congressional leaders, to representatives who can help advocate for additional resources for disinvested communities? And finally, would you learn how to use Narcan? It is such a simple process and an easy, readily available tool. You can check our website to see where there are opportunities to access Narcan or how you can become trained. I believe every single Chicagoan should know how to use Narcan and should actually have Narcan. It is widely available. You can check our website to see where they are. It is in every public library in the city of Chicago, and we want you all to be able to use it. And we will continue in our role to provide information, to provide resources, to meet the communities where they are, and to be there on the ground, making this a priority like it should be, and continuing to call for your support for how we can reverse this trend in overdose death in the city of Chicago. I thank you for taking some time out with us today to listen to the work that we're doing, to learn more about the people in CDPH who are on your behalf fighting to keep Chicago safe. Thank you, Matt, for coming to hang out with me and for sharing your story and be so authentic and passionate and compassionate in the work that you do. Folks, as always, health is wealth. Health is a priority. There are many public health issues that we are tackling, and this is a priority for us for the summer of 2024. Please join us and take a moment to check out our website for how you can be part of the solution.
And that's our show. Thanks for joining us today. Don't forget to rate and subscribe wherever you find podcasts. I'm Dr. Bora, and we'll see you next time.